Hello, everyone, and welcome to this session of today's events. I'm Dr. Doug Spegman. I'm Chief Clinical Officer here at El Rio Health, and just very excited to again be hosting this program. As those of you who were listening in on the panel discussion heard from Dr. Perez, that this is our 7th annual research poster fair. And we were interrupted by COVID for a few years, but we are just delighted to be back in this forum. And this session is expressly for the purposes of handing out the poster award winners. We received and reviewed 38 presentations over 8 different categories of community health projects, QI projects, and research efforts based on clinician-based dental, environmental or occupational health, health and wellness, community engagement and outreach, maternal child health, pharmacy, and social determinants of health and healthcare use. And I just wanted to say that our efforts in this regard is really to create a forum, a robust forum between quality improvement, research, between academic partners, teaching health center partners, residents, students, community members, so that we begin this very iterative process of guiding community-based research, both for our student learners, but primarily to engage community in a very different sense and to guide our activities based on community needs and with community response. So I do want to, before we begin the poster award winners, to introduce our new CEO, Dr. Clint Kuntz.
Thank you, Dr. Spegman. Just really excited that El Rio is able to host this event, and really want to give a lot of thanks to the SAHAC team, Dr. Perez, and also to Dr. Daugherty for all the work that they all have put in, and so many other people as well. We had a great judging panel that did some tremendous work reviewing all of these amazing presentations and the amazing research done behind them. So I'm really excited to see us give these awards now and to go through that whole process. So I just want to, again, say thank you to everybody who made this happen. And so much work behind the scenes to make this work. And this new innovative platform, doing this as a virtual event, has been really exciting to watch today. So just great job. Thank you, everyone. Thank you to all the participants who've done just an amazing job with their posters as well. I've really enjoyed getting to see them. So Dr. Spegman, I'll turn it back over to you.
All right. Thank you, Clint. And again, I also want to call out specifically Desiree Rose, and she is the glue that put all this together. And so thanks, Desiree. So we're going to move forward into our first award, which is our Innovation Award. And the Innovation Award is, the poster that provides new information or unique practice models, contributes insight into important and timely research, or improving patient care. And this year's winner is Haley M. Cito, Ashley M. Campbell, Dustin Holloway, and Amy Kennedy on describing anticholinergic burden in patients with mild cognitive impairment or dementia.
Okay, I'm sharing my screen, and first we're going to watch the oral abstract that was.
Hi, my name is Haley Cito, and I'm the lead researcher for the project describing anticholinergic burden in patients with mild cognitive impairment or dementia. The purpose of this project was to quantify and describe anticholinergic burden in patients with MCI or dementia using the Anticholinergic Cognitive Burden Scale, or ACB scale. There were 225 patients included in this retrospective study, and 156 out of 225 patients were found to be using at least one anticholinergic drug. 77 of these patients, or 34%, had an ACB scale score of 3 or greater, indicating clinically significant anticholinergic burden. The average total ACB scale score was 2.93, and the most common score, when only considering patients who were on an anticholinergic drug, was 1. The most common drugs with anticholinergic activity were trazodone, metoprolol, tartrate or succinate, and furosemide, all of which have an ACB scale score of 1, indicating possible anticholinergic activity. These medications are typically used in chronic disease states like hypertension and heart failure. The most common drug classes were antidepressants and antipsychotics. There were 109 patients using a cholinesterase inhibitor and/or memantine, and 50% of these patients had an ACB scale score of 2 or greater, meaning that they either were using more than one drug with anticholinergic activity or were using a definite anticholinergic drug, meaning it had a score of 2 or greater. There were 97 patients hospitalized at least once during the study period, and the odds of hospitalization were significantly increased for patients with an ACB scale score of 2 or greater, but were not increased for patients with an ACB score of 1. Anticholinergic burden has been linked to worsening cognitive and physical function, as well as possibly increased mortality for older adults with dementia. However, there have not been any studies looking at the impact of interventions to reduce anticholinergic burden in this population. The results of this study show that over 1/3 of older adults with dementia experience clinically significant anticholinergic burden, and it hopes to serve as a foundation for future studies, as well as looking into the implementation of interventions to improve the quality of life for these patients. Please let me know if you have any questions or concerns. Thank you.
So again, congratulations to the group. And I believe, Haley, you are now on with us. And if people have questions for you, we have about 6 or 7 minutes for some debrief. I'd like to start off just by asking you, when you guys took total number of patients that you studied, how did you select the patients, and were you able, with data that wasn't shared, to look at any age-associated differences based on the patients that you studied?
Yeah, so overall, I was kind of given a list of all the patients at El Rio who have a diagnosis of mild cognitive impairment or dementia, and I simply used a sample size calculator to figure out how many patients to grab, and at that point, it was just at random. For age-related differences, the only thing that really stands out is that the majority of patients in the study are between ages 75 to 85. But within the entire group, there's not too much of it. There's really no difference in the types of drugs that they're using or their score.
Great. And I just want to take a minute and remind people that there is a Q&A icon that should be to the right of your screen. So please feel free to enter any questions there. So Haley, why were you interested in this?
I think I was interested because my initial interest was looking into polypharmacy and prescribing cascades, and looking into potentially inappropriate medications for older adults, and anticholinergics seem to be coming up fairly frequently. And then when I started to look into the data that was available, there simply wasn't a lot of information when it comes to anticholinergic burden experienced in the specific older adult population with dementia, and we don't have any recommendations for interventions for this. And because we know that anticholinergics are linked to worsening cognitive function, worsening physical function, and potentially increased mortality, I think it's a huge area that's kind of left in the open that we should be looking into. So I wanted to make sure we could gather the information, see what it looked like compared to the general population, and kind of go forward here. Do we need interventions or anything like that? So just a good starting point.
Yeah, no, it's a great question to ask. You pointed out that the cholinesterase inhibitors that were being used, and found a good percentage of people on that with high ACB scale scores. Can you just speak to pharmacologically, like, what does that say to you, and what might be one of your interventions that you would put forth?
Yeah, so kind of just looking at the two classes, they more or less clash and do almost opposite things. So one of the kind of thoughts is that patients who will maybe start a cholinesterase inhibitor and start to develop side effects, we're not fully evaluating that they are indeed side effects, and we could dose adjust, and instead we start in an anticholinergic, for example, for urinary incontinence, something like that, starting them on oxybutynin instead of looking at the patient as a whole and adjusting the medication. So that's probably one of the main drivers for why we see so many patients using both of the medications. It's probably a prescribing cascade.
Yeah. And I want to peel that onion back a little bit more, but first, just housekeeping wise, do we have any other questions submitted? I'm not sure that I can see that on my end. Well, not hearing any. So let me just go further. So as you when you got these results and did this retrospective, any surprises for you? And then the corollary question after that is, what's next? What do you want to do with these results? And what specifically do you think needs to be done for the good of our community?
Yeah, so I think the thing that jumped out to me the most with the data in general was the amount of antipsychotics that I identified for patients who are over 65 and have dementia. Given their black box warning for increased risk of mortality, it is a little concerning to see that it's the second most common drug class identified. So in the case of this specifically, I'm currently working on a quality improvement project to address either provider understanding on the risk versus benefits, what would really be first line for patients who are potentially using this for behavioral symptoms of dementia, and what would be alternatives like non-pharm therapy or trying an antidepressant instead. So that's a big step that I've taken just based off of that. But I think in the grand scheme, looking in to see, for example, risk or the patients who are hospitalized, is it truly due to anticholinergic burden, or is it just happenstance? I think that's a really big area to maybe look into further. And then kind of assessing, is there an intervention that we can do, maybe reducing the amount of anticholinergic burden that patients are experiencing? Does this improve quality of life or any other factors?
Yeah, that's great. Were you able to get a sense by any other demographic, ethnicity, or gender data that you collected of any potential disparity amongst the data that you saw?
Surprisingly, no, there was no, in general, patients, women have dementia more often than men, essentially. It's more common in women. So that was evident in the data, but it wasn't necessarily that the women were experiencing more anticholinergic burden than the men were. It's just that they made up a larger portion of my sample. But other than that, there were no real disparities that that popped out for me in the data at all.
All right. And just in terms of your own career as a resident, how do you think this research will impact your eventual career goals?
I think that, with our aging population, being a pharmacist and hoping that pharmacists have the opportunity to step into primary care, into these more specialized roles, we can really help to improve quality of life, knowing that this anticholinergic burden may be playing into worsening symptoms for older adults with dementia, gives me, all the more reason to recommend deprescribing, which is becoming kind of a hot topic. So feeling more knowledgeable in that will only be helpful going forward with recommendations and implementing it in my own practice.
Well, again, congratulations. Any other comments that you would have for the people who are, listening in, who saw the work that you did? Any last comments that you might make?
I don't think I have any extra comments, but I appreciate everyone who looked at my presentation into the research and the opportunity to receive this award. I really appreciate it.
Oh, great. And again, congratulations. Well done. And now I'm going to interface with those who are coordinating. Kirsten, are you at the controls now?
Oh, not yet. She will be when I leave, but I'm gonna go ahead and do you want to introduce the next while I pull up the video? And also, is it helpful to leave once the oral part is done, to leave the screen on share so everybody can see the poster more closely?
Yeah, I think so. And is there any way that I can see when questions are posted?
Kristen will text them. She'll direct message you what the questions are or read them to you.
Okay.
Yes.
Okay. Thank you.
Yep. I'm going to pull up the video, and if you want to introduce the next.
Yes.
Hello.
So,
Rose.
Hold on, gonna pause it. Okay, go ahead.
okay, so the next award category is Relevance Award. And that's the topic is both pertinent and of great interest to community health centers and integrated care. And this year's award winners are Emily Crows, Christina Medvesic, Alma Anderson, and Alicia All, who studied modifying exogenous hormones to prevent postpartum smoking relapse.
I am the study coordinator on this project. I work at the University of Arizona College of Medicine on the ReNU team. So I'm just going to go ahead and present my poster titled Modifying Exogenous Hormones to Prevent Postpartum Smoking Relapse. So just to introduce you to this project and why we're doing what we're doing, up to 90% of women who quit smoking prior to childbirth relapse within 12 months of delivery. In addition to the health risks of smoking relapse, mothers are also the primary source of secondhand smoke exposure for children. And previous studies have linked sex hormones with differential smoking cessation outcomes. So the PEACH project, that's the title for this project, that stands for Protecting Families by Ending Addiction to Cigarettes with Hormones. The PEACH project is a novel clinical trial that will determine the efficacy of using exogenous hormones to prevent postpartum smoking relapse and reduce infant secondhand smoke exposure, which ultimately will improve health outcomes for families and communities. So our objectives for the study is to determine the efficacy of progesterone in preventing postpartum smoking relapse and reducing smoking relapse risk factors, examine the effects of this maternal smoking intervention on infant health, and to also examine racial and ethnic differences in intervention outcomes. And this is a double-blind randomized clinical trial recruiting healthy individuals from Arizona and also Minnesota who are pregnant or up to 2 years postpartum and who have either recently quit smoking cigarettes or are motivated to quit. Participants will be randomized to either receive active progesterone or placebo. And over the 9-month study participation period, participants will collect biological samples, complete surveys, and participate in relapse prevention counseling. And all study procedures will be completed remotely, and participants will be recruited statewide. So this first figure I have here is just an overview of the study design and the process of it. The second figure here is the anticipated progesterone and estradiol levels by randomization group and breastfeeding status. So we will assess the effect of the exogenous hormone administration in the postpartum period on smoking behaviors and symptoms, and findings from the study will inform novel approaches to postpartum smoking relapse prevention, improving the health of mothers and families. So pregnancy and the postpartum period represent a unique opportunity for smoking cessation interventions, and the study seeks to bolster existing evidence on the relationship between sex hormones and smoking cessation while presenting a novel approach to the postpartum relapse prevention. Based on evidence from this clinical trial, it may be possible to recommend progesterone as a low-cost, non-invasive smoking cessation aid in the postpartum period. Thank you for listening.
Thank you, Emily, and congratulations to you and your team. So
Thank you.
the judges, I'm assuming, were really taken by both the relevance, but also probably by some of the novel aspects of what this will study. So could you just maybe help us understand, because I think there are probably a number of people out there that are just saying, what? Tell me why progesterone and why that
Yeah.
might have an effect.
Yeah, definitely. Good question. And thanks again. So we're noticing, and these are just kind of general overarching statements, but just to give a little bit of context. So men are more likely to be addicted to substances, but women are more likely to relapse or have a harder time like staying quit or quitting in the first place. And the theory surrounding this sort of like difference based on sex and addiction is hormones, right? So women have a different hormonal cycle. And in preclinical trials, it was found that progesterone helps stop things like cravings or that impulse to, for example, pick up a cigarette, versus hormones like estrogen might increase those cravings or increase that impulse to want to smoke or take a substance. So that's just a really quick little background, but we are finding that there are hormonal differences to behaviors and addiction.
Well, and that's fascinating. So you're centering on nicotine and tobacco, but will you also, based with the opioid epidemic, be looking at other substances of addiction?
Yeah, that's a great question, actually. So our team works primarily with mothers who struggle with addiction, so various kinds. So one of our other projects called the ORCID study. It's an observational study, but we are looking at how mother-baby bonding hormones, like oxytocin, can be protective against opioid use disorder relapse. So, you know, when mom spends time skin to skin with her baby, that produces different hormones, which could be protective against relapsing, which is kind of interesting. So we are looking at other types of addiction and different substances, and also different hormones as well, and how these affect all of those things.
And so with this current study under the PEACH protocol, will you be looking at the effect of oxytocin as well for teen tobacco?
Not specifically for PEACH. Right now, we're just looking at progesterone, but we are very open to expanding in the future, especially with how it relates to our other studies. We have another study coming up that is looking more hands-on on different types of like baby wearing. Like you have a baby in a stroller, a baby in a sling, a baby skin to skin, and then measuring those different hormones and then kind of seeing, okay, who relapses, who doesn't, that sort of thing. Who reports more cravings or less cravings and that sort of thing as well. So we are looking at that in other projects, specifically for PEACH, excuse me. We're just looking at progesterone right now.
Well, great. So with progesterone, getting back to that specifically, will you be looking at a dose response or not? A single dose? What is the intervention?
Sure. Yeah. So the actual intervention is one pill in the morning and then one pill in the evening um, for 14 weeks.
And single dosing of it, not
Mhm.
not a step dosing.
Yeah.
And then just interested because you mentioned the catchment areas for recruitment, Arizona and Minnesota, very different.
Yes.
So
Yes.
what have you thought about in terms of overcoming that barrier, and what unique opportunity might that present for you?
With the two different sites, you mean?
Yes.
Yeah, so that definitely has been a challenge and a learning process for all of us involved. So Dr. Allen, Alicia Allen is the PI on this project, and her mentor is Dr. Sharon Allen, who is the PI for the project in Minnesota. So they've been colleagues for forever. So that's kind of how that came to be, and this is both their subject of interest. So that's how those two sites, kind of happen. But there are very different demographics between Arizona and Minnesota. So that's kind of one of our exploratory aims, is to look at specifically demographics of the two areas and to see what differences there are.
Well, yeah, I think it really lends itself to look at ethnicity, race, as well as gender, but and the effects that it might have.
Exactly.
Personally, for you, what is your passion for this topic in particular? And you've kind of approached it already in some of your answers, but why is this, in your mind and in the judge's mind, a topic of such relevance?
Yeah, that's a very good question. I like that question. I think just for me, for the work that I've done on this project, I really love getting to know the women and their stories, because I think when we especially approach the topic of addiction and motherhood, it's a very stigmatized topic that people don't really understand. So I think getting to know these mothers who have a history of addiction, whatever it may be, I've also worked on the Orchid Project as well. It's really, I'm going to medical school in August. And so I've gotten a ton of experience, and my understanding of what addiction looks like and what motherhood looks like has just blown up. It's really amazing just to get to talk one-on-one with these women and get to know them. And I mentioned in my poster we do relapse prevention counseling, and so that's something I'm super passionate about. Getting to actually help this population is really amazing. And then, I'm sorry, you had a second part of your question.
Well, it was, and I'll change it and modify it a little bit because you're going to medical school. So how has this research impacted you, and where will it, you think, impact you in the future in your clinical degree?
Yeah, good question. I know personally, like where my passion lies, I know that I want to work with kids, and I know that I want to work with families. Pediatrics, family medicine, definitely primary care for me. And so I think now knowing, I mean, that first statistic, up to 90% of women who quit smoking prior to childbirth will relapse in 12 months of delivery. I never knew that. Right. So that's brand new knowledge. And so now I know that this is a vulnerable population that is often overlooked because of that stigma that goes hand in hand with addiction and motherhood. So I think as, a future physician, I'll be able to approach that with a bit more sensitivity and understanding, because I have worked so closely and very directly with this population. I meet their babies when they're 4 days old, right? And then I get to see them until they're 9 months old. So I think it's just a really one-of-a-kind experience, and has opened my eyes to a lot of things. And I think it'll definitely allow me to, I mean, if everything works out and progesterone turns out to be a treatment for this, then awesome. I can use that in the future as a physician. But just, from the empathy standpoint, I think that's huge. I've gained a huge understanding from this project.
Well, great. Thank you very much. And again, congratulations to you and your team.
Thank you very much.
So we will now move into our next category, which is the Community Impact Award. So just wait for,
I had to pause it, so yeah, sorry, okay, I did it, I'm good, okay. Oh, I have to open it again. Here we go.
great. So now we move on to the Community Impact Award. This poster discusses, or the winner of this category discusses the impact on health outcomes in the community, clearly describes and demonstrates community involvement. And congratulations, this year's winner, Anna S. Gonzalez, Rosie M. Vogel, Edgar A. Villavicencio, Adriana Maldonado, and David Garcia for their work on community education for the prevention and treatment of liver disease.
The project, Community Education for the Prevention and Treatment of Liver Disease, is an ongoing project built upon past and current efforts where the Nosotros Research Group scanned 700 individuals in the past year in 2022 using a FibroScan, which is a non-invasive device that determines the levels of fat and levels of scarring in the liver. Now, in 2022, nearly 60% of individuals scanned by Nosotros were identified as having NAFLD. NAFLD, or non-alcoholic fatty liver disease, is a well-established risk for hepatocellular carcinoma or liver cancer and cirrhosis. And really importantly, NAFLD most often does not have symptoms, so a person could be walking around with NAFLD and it could progress into cirrhosis or cancer, and at that rate, it is irreversible. The good news is that NAFLD is reversible, and that is where our efforts come in, as we are able to scan individuals for free and provide them with a big picture of the levels of fat and scarring in their liver, and they're able to make the necessary changes, such as dietary changes and increased physical activity. With these past efforts, we found that people needed and wanted more in-depth education and support on what they can do for themselves and the people around them. In response, we created a 30-minute presentation for community stakeholders, specifically promotoras, for them to be able to learn about NAFLD, liver disease, and nutrition and lifestyle, and enable them to go out and refer people to us and explain to people how important it is for them to be scanned. And the other aspect, we increased the education for the individuals getting scanned. And so after they receive their scan, we provide an explanation on the results, and we give them individual support and education on how they can prevent or lower the levels of fat with nutrition and increase physical activity. Since it is an ongoing project, our efforts are anticipated to reduce the number of individuals in Southern Arizona with advanced stages of NAFLD, which would ultimately reduce the health burden associated with this disease. In future projects, we hope to track participant lifestyle changes and their results after receiving this education, while we have individuals come back to us 6 to 8 months after their scan and have seen lower rates of NAFLD. We hope that we can create a cohort where we can specifically track how our education enables people to make these necessary changes. Thank you.
Anna, congratulations again to you and your team. Maybe we can just start off for people who are not familiar with the Nosotros team. Can you just explain to them who you are, how you interact with the community, and really your methods?
Yeah, so the Nosotros Research Group is a research group part of the University of Arizona MESCOF. And our big focus is community outreach and research. So we center our research based on the community needs, and what they want to learn about more. And our focus is, and we work with them specifically. So we go out to the community. We do a lot of events at the Mexican consulates. We have gone to Nogales, Douglas, Yuma, TUSD, Family Resource Centers around Tucson. And we try to decrease the health barriers for people, whether it be transportation, lack of insurance, and economic burdens.
Yeah, well, thanks for that. It's a great effort. And I'm not asking this question. Dr. Garcia didn't ask me to ask this question.
Okay.
But I'm going to ask, usually in community health efforts, we've long thought and said that if you impact the mother of a household, frequently then you'll move the health literacy of the family, and that is true. However, a barrier that always remains is, how do you reach the male members of the household, especially within parent groupings? And so could you speak to that? Because I do know that you, in your group's research, you've specifically looked at how do you bring men, Hispanic men, from pre-contemplative to a contemplative state where they're willing to engage. So any comments on that?
Yeah, so this specific project wasn't just men. We have done previous projects with just men, but this one, actually, interesting enough, I think showed us that, like you said, the women in the household are very important, especially in Hispanic or Mexican households, where the men are used to diminishing their pain and not wanting to see a doctor. We have found that women who come in and tell us that their husband was scared to come in or kind of just didn't have any interest, we have found that they are sometimes able to convince them after seeing themselves how willing we are to help and how easy it is for them to receive this scan, and how we do it for them. So they should be in a comfortable setting.
Well, and so to that, how important, obviously, this is all about, in some ways, this is, just using my simplistic way of looking at it, is dangling a new object in front of people, a fibro scanner, and saying, wow, look what we can measure, and using that, if you will, as a public health hook to get people onto a path of wellness. So speak to that. How important do you think is the fibro scanner itself in all these efforts?
Yeah, I think it's very important. I mean, when we recruit people, we emphasize on how much this scan usually costs, which is around $300 to $500. And specifically in Hispanic communities where sometimes they don't have access to care or insurance, telling them how this very advanced tool will be completely free definitely motivates them to come in.
And I realize that a lot of the results are preliminary. You're doing ongoing studies.
Yes.
But of the 700 individuals that were screened, where do you think the research will take you? So again, I know a lot will be done over the ensuing years, but what exciting things have you seen, and where do you think it'll direct your guys' efforts?
I think there's definitely so many different aspects or routes we can take. One of them being social networking to decrease liver disease or even liver cancer. Another one can be the relationship of liver disease to mental health disorders or other disorders. And I think off the top of my head, I would say those two are big ones, but there's definitely a lot of ways we can take this.
And then lastly, let me just ask you on a personal basis, why are you passionate about this, and what does it mean for you and your career?
Yeah, so I'm a Mexican immigrant, And I've been through the healthcare system through my own personal health issues, and I have seen how hard it is to navigate the healthcare system here in America, especially after migrating from a completely different country. So since I was little, I knew I wanted to help people and help people in my community who often don't have a voice and often don't have people representing them. So that's, the main point.
Well, that's great. That's inspirational.
Mhm.
Any other comments that you would like to make about the research or anything else that you presented?
Yes. So we are currently still scanning people this year. This year, we've almost reached, I think today, around 260. So if anyone wants a free liver scan, you can contact us. There's at the bottom the QR code, and you can come in. It's really easy, painless, and we can give you the results right away.
Fabulous.
Yes.
Well, Anna, congratulations and thank you and your team for the work that you're doing.
Thank you.
All
And
right,
thank you for listening.
you bet. So we'll transition now to the last category, and I'll wait for it to be teed up.
Our presentation.
So this category is the best overall, also known as Create Tomorrow, Carlos M. Flores, MD Award. Specifically, it's about really embracing innovation in a way that is impactful for community medicine. I just want to take a moment. Carlos Flores was a clinician in our community. He was a neonatologist, worked at TMC and other areas. He was also a board member at El Rio, and he was very, very committed to quality improvement. And tragically, he died fairly young from colorectal cancer. And this award, though, is in honor of him. So this year, the award winners are Kimbriana Washington, Rebecca Rodriguez, and Rue Arce. And specifically, they studied improving diabetic outcome measures using population health technicians and targeted outreach at El Rio Health Center.
Our presentation is improving diabetic outcome measures using population health technicians, or PHTs, and targeted outreach at El Rio Health Center. And our names are Rue Arce, Kimbriana Washington, and Rebecca Rodriguez. So to give a little bit of background information, this project was started at the Southeast Clinic as an effort to try and motivate more diabetic patients to come in to complete their hemoglobin A1C lab. According to the American Diabetes Association, this lab should be completed every 3 to 6 months, and completing it can help in understanding how best to manage diabetes, which means better glycemic control and patient satisfaction. As for the role of PHTs in this project, it was created to help bridge care gaps, and as non-traditional healthcare team members, we provided additional services through retinopathy screenings as well as outreach.
Next, looking into our objectives, the purpose of this effort was to measure how outreach would first impact the number of diabetic patients with uncontrolled hemoglobin A1C levels more than 9, and secondly, the number of diabetic patients who completed their annual or biannual retinopathy screening. The methods all three of us are trained in includes motivational interviewing, diabetes physiology, quality measures, and social determinants of health. We've cultivated patient panels whose hemoglobin A1C was uncontrolled or uncompleted. We've outreached to all El Rio health clinics and utilized motivational interviewing to encourage patients to complete their labs and schedule appointments with their providers. Additionally, we became certified retinopathy photographers to perform retinopathy screenings at the Southeast Clinic.
In the next section, we will discuss the following graphs. The first graph demonstrates diabetic HbA1c control across all El Rio sites. The higher points represent a higher percentage of uncontrolled diabetic patients. We began our work at the beginning of Q3 of 2022, which is where the drop in percentage begins. The dotted line across the graph represents a quality measure that El Rio wanted to meet for their uncontrolled diabetic patients. The data indicates that we went beyond this goal at 31% at Q4 of 2022. The second graph reflects the percentage of retinopathy screenings completed at the Southeast location. The percentage of completed screenings remained relatively stagnant at around 34%. We began the screening around Q3 of 2022 with 34% completion and have increased to 75% completion in Q2 of 2023.
In conclusion, there has been a decrease in uncontrolled hemoglobin A1C levels and increase in completed retinopathy screenings, which may indicate that focused outreach impacts quality measures in patient management over their diabetes. The role of PHTs has also served to overcome staffing challenges. This concludes our poster presentation, which was funded by the HRSA Hypertension Grant and initiated by our supervisor and the Chief Quality Officer, Dr. Rajiv Modak.
Well, congratulations, Kimbriana, Rebecca, and Rue. You guys, great job. For the audience, can you guys talk a little bit more about population health technicians? You were the inaugural class to begin that new project. So talk a little bit more about it, what you guys have learned from that role, and how it impacted the study.
Sure. Well, thank you. So we're the population health technicians, and as Dr. Spegman mentioned, we're the first to do this. And so as we started out, I think our role was very much up for interpretation. But here at Southeast, we have a population health group where the nursing staff, providers will meet to talk about quality measures that could use improvement here at the Southeast Clinic. And when Dr. Modak piloted this project, his focus for us was to improve the hemoglobin A1C measure. And so what we do on a daily basis is look through the list of those patients and do targeted outreach. So that includes the phone calls, the MyChart messages, and sometimes even meeting with them in person while they're here in the clinic. And as I mentioned, our role was up for interpretation. Diabetic patients have a lot of care gaps that they need to fulfill. And one of those care gaps that we noticed was the retinopathy screening. So we became retinopathy photographers and started closing that gap even more. But other things that we kind of note in the chart while they're here for a visit is maybe they need a diabetic foot exam, or they need to get their lab done again. But again, our role is very open to what we notice is missing, and we do what we can to try and close that.
Well, thank you for answering it that way, Rebecca. I wanted to ask, what were the barriers potentially that you experienced as you were developing a new team role, and barriers with other team members potentially, but also with patients? What has your guys' experience been? And you can take it either barriers or successes, go both ways.
I think so. Some of the barriers I can think of off the top of my head, there were a lot of patients we just weren't able to reach over the phone, to which we would follow up by sending MyChart messages or sending them a letter. There were also patients that didn't speak English, and so we also did our part to try and fill in those gaps, the barrier gap, by speaking Spanish to them and trying to get them to come in for labs or whatever it was that they needed. And then there were also sometimes difficulties in communication with other staff when we first started, because we were new to the clinic, and doing retinopathies required a lot of communication with medical assistants, with providers, trying to get them, the patient, to move from one room to another very smoothly, without missing anything if they needed other paperwork or to see the provider.
Yeah, and to kind of build on what Rue was saying, we're non-traditional healthcare workers. We don't have medical degrees, we don't have certification, and our role is new. And so kind of establishing our place here in a clinic setting was that barrier, was trying to find our footing in like how we interact with the medical assistants and the providers. Because again, we're not medically trained, but we're working with a population that is all about their healthcare. So it's been a great learning experience for the three of us to be young people and to be non-medical working in this field.
Well, so let me follow up on that, and maybe Kimbriana, you can lead out with this answer. How has this work impacted you personally, and what has it meant for the future for you?
Yeah, so personally, I feel like when I was first introduced to this position, I kind of resonated with it because I've seen kind of directly how someone with uncontrolled diabetes, how much it can affect a person on their health, how much you're at more risk for other conditions such as gangrene retinopathy, blindness, kidney failure, conditions like that. So I think this has really kind of expanded my knowledge of diabetes and just the physiology and like how much it can affect a person. So I think I would have to say that. And then for the second part, I would have to say just overall, I feel like us doing this work is like it's the first like point of like patients getting to know what exactly is going on with them. And for them to even get to know that, they can, coming into their visits with their doctors and getting their labs done, they know. And so just in that, they have more control over, okay, I can keep going to getting my labs done every 3 months. I can keep going to my doctor's visits, and this can help improve my hemoglobin A1C, and this can prevent these future conditions that could happen if their A1C remain uncontrolled.
Well, and thank you for that. It sounds like these efforts were empowering for each of you, but equally and potentially more importantly, empowering for the patients that you are serving. Maybe this will be the last question. What recommendations do you have based on this for your innovative project for the future?
I think expanding this project to other chronic illnesses might be really beneficial to our general patient population, just because our focus for this first phase was really just diabetes. And seeing what an impact it made on our numbers has really inspired us to try and broaden our scope. Like we've started to do outreach for hypertensive patients and trying to get them to come in for blood pressure checks. And we've already started to see those numbers decline a little. So I think just having us have this focused outreach can really help lower, improve chronic illnesses across a broad scope of patients.
Great. And any last comments or points that any of you would wish to underscore for the audience?
Yeah, I think, we're proud of the work that we've been able to do and are, pleased with the impact that we've made at El Rio. And, the proof is in the numbers, but this is an effort done by more than just us. We do the phone calls, but the people behind this work are the providers, are the MAs, are the nursing staff, really everyone, the lab staff, like everyone that's interacting with our patients, they're the ones that are directly making this impact. We're just helping bring them in to see the wonderful staff that are here at El Rio. So we want to extend our thank you to everyone at El Rio.
No, well, very gracious, and I agree.
Dr. Spigman, I just have one question in the chat.
Oh, yes, go ahead.
It says, how do the patient population health technicians improve SCOH, and what social determinants are most significant, and how do you measure this?
So we improve social determinants of health mostly by the conversations we have with our patients over the phone, whether it's trying to determine if they've had visits to ophthalmology, we need to request records, or just trying to get them to come in for either a visit or for their A1C. We usually pick up on whether a patient, the most common one is that they're not able to come into the clinic because of transportation issues. And to that, we're able to connect them directly to our CHA, which is the community health advisor. Or if a patient is uninsured, we do the same. We're really just helping them navigate from us to someone who's more specialized to take care of them and connect them to community resources.
Great. Go ahead.
Yeah, as to what social determinants are most significant, the transportation and insurance are really big ones. And then we also run into, sometimes when we do retinopathy screenings in person, there's other, maybe like patients who have language barriers, and we're able to use an interpreter. Yeah.
El Rio is a healthcare home, and I think because of the abundance of resources that El Rio has, it's a good thing, but also easy for patients to get lost or just not understand. And so we're like health navigators. We just point our patients in the direction that will best serve them. And all of that is usually found within El Rio. And we don't necessarily measure it in numbers. It's more just about what we remember and what we come across. But we have helped the clinical pharmacist in tracking. We did a project where we tracked what was keeping people from following up on their referrals, and it was the same thing that we encounter day to day when we do the calls, which is the insurance and the transportation and the language barriers.
Well, Kimbriana, did you want to add anything to that?
No, I think she said it perfectly well. Yeah.
All right. Well, look, Rue, Rebecca, Kimbriana, congratulations. Very proud of the effort that you guys have done, and I know under the mentorship of Rajiv Modak and all the other teams. So congratulations and well done.
Thank you. Thank you so much.
You bet. So for the rest of the group, just wanted to thank you all for being part of this, and thank you for everyone who participated. Everyone has done very meaningful work in the space of bringing community health research and quality improvement to a level of not only practicality and high impact, but brought it to a level of transparency. And that is the whole purpose of what's behind the El Rio Research Fair, is to bring all these groups together. And hopefully today, you've seen some indication of that with the award winners. We would now like to invite everyone to join us at the meet and greet. And that would be to go back on your web page that was the invitation page to the sessions. And you'll see it should be listed by time. Individuals that are available to virtually meet and greet with you, and for you to interact directly with the researchers and presenters. So again, I want to thank you all for being part of this effort. And again, special thanks to all the award winners. Kirsten, is there anything else that we need to do on this